Let's look at this study. Medical Gas Research 2018, Safety and Efficacy of N-acetylcysteine for Prophylaxis of Ventilator-Associated Pneumonia. So this is actually a remarkably positive study that I actually like quite a bit. So they used NAC 600 milligrams twice a day. Now, why would I support or be excited or positive about a study that used 600 milligrams twice a day for a total dose of 1200 milligrams? Why would I give this more time than the other articles that we just looked at when they used approximately the same dose, either 600 milligrams per day? The other study used 600 milligrams per day as well, and the other one used, I believe it was 1200 or maybe 1800 milligrams per day. So why were those studies underdosed? And I'm willing to say that this study was appropriately dosed, or at least marginally appropriately dosed. And the difference is quite obvious. If you just look at what I've already stated here, they're using a lower dose here, which is appropriate for prophylaxis or prevention. In all of the other studies that we already looked at, the patients already had AIDS, they already had HIV infection, or they already had acute hepatitis from a viral source, acute viral hepatitis. These patients don't have pneumonia, so they can be treated with a lower dose of the intervention because we're using it for prevention. We're not using it for active intervention. That's the distinction here. And you're going to see that this is a theme that repeats itself throughout the articles that I'm going to review. When we're using NAC for preventive means, for preventive measures, we can use a lower dose because typically preventive doses are lower than interventional or therapeutic doses. So again, they used NAC 600 milligrams twice per day via nasogastric tube. Patients treated with NAC were significantly less likely to develop clinically confirmed ventilator-associated pneumonia, and that's huge. So the difference here was a reduction from 46% in the placebo group to 26%, and that's huge when we're talking about a very dangerous condition, again, ventilator-associated pneumonia. So we have to evaluate safety, efficacy, and cost-effectiveness within a clinical context. And in this case, we're talking about ventilator-associated pneumonia, which is very lethal. So let's go on and look at some more details. The patients treated with NAC had significantly less ICU length of stay, less hospital stay, and the incidence of complete recovery was significantly higher in the NAC group, 56% versus 30%. So across the board, basically what you see is a 20% or almost doubling in some cases of the benefits seen in the treatment group versus the placebo group. No adverse effects. And my comment on this article is that these results are statistically and clinically huge, and this one article could have established a new standard of care for the prevention of ventilator-associated pneumonia. The authors also include some background information in their article, as any good authors would. The effectiveness of NAC has been shown in patients with some lung diseases, such as acute respiratory distress syndrome, idiopathic pulmonary fibrosis, chronic obstructive pulmonary disease, influenza, especially influenza A, cystic fibrosis, and smoking-related lung damage. So this was a remarkably positive article. And again, they could use a lower dose because they started with patients who didn't have the index disease. Prevention requires a much lower threshold of intervention than does active intervention for an already established disease. So let's take a look at this article from the journal Medicine 2018 in November. N-acetylcysteine improves oxidative stress and inflammatory response in patients with community-acquired pneumonia. They used 1,200 milligrams per day. So let's just stop right there. Is 1,200 milligrams per day an appropriate dose in this setting based on what I've already told you? The answer obviously is no. These patients already have pneumonia, so they need to be at a therapeutic dose, not a preventive dose. Again, these are patients with community-acquired pneumonia, either bacterial and or viral. Sometimes it's a combination, sometimes it's one or the other. So they did show some biochemical improvements, but nothing radical in terms of clinical improvements. So that's great, excellent safety, low cost, wide availability. Let's look at the conclusions here. Our study suggests that NAC inhibited oxidative stress and reduced the inflammatory factors in pneumonia. Treatment with the antioxidant NAC might reduce oxidative and inflammatory damage in pneumonia patients. Now, the only thing that remains to be done is to repeat this study with an adequate dose. 1,200 milligrams for active treatment is inadequate. Let's look at another study here. So this is actually just a case report. This is from Annals of Internal Medicine, 2010, published in May. I provided a little bit of an image, not the entire article here, but I did provide you some of the excerpt there. This is a 40-year-old woman with H1N1 influenza pneumonia, septic shock, respiratory failure, treated with various drugs and antibiotics, even though no bacterial infections were found. That's still basic protocol. So in hospital settings, if a patient comes in with severe pneumonia, septic shock, they're going to get put on antibiotics while we're waiting for the culture results, because there's just no time to waste. We can't sit around waiting on test results while this patient's crashing and crumping right in front of us. So the fact that they started antibiotic drugs, even though the patient didn't have a bacterial infection, that's certainly consistent with appropriate care. At that time, the patient was started on NAC intravenously at 100 milligrams per kilogram. So let's assume that this patient weighed, I don't know if it's stated in here, but let's assume this patient weighed 70 kilograms. This would have been 7 grams per day of NAC. Now, 7 grams is very different from the previous study that we just looked at, where they used 1,200 milligrams for community-acquired pneumonia. So in this case, we're looking at a more severe disease. This patient's already in septic shock and respiratory failure. So again, they used 100 milligrams per kilogram IV for 3 days, 100 milligrams per kilogram. Let's assume she weighs 70 kilograms. That's 7 grams per day for 3 days. Then they withdrew the high-dose NAC and they put her on oral therapy with NAC at 600 milligrams twice per day, so 1,200 milligrams. So, of course, no surprise, the patient crashed after that. So, patient responded very well to 7 grams per day. Then, when they reduced that to 1,200 milligrams per day, the patient crashed. Then they reinstated the 100 milligrams per kilogram, and the patient was cured of her septic shock, pneumonia, and H1N1 and went home after 20 days. So even though this is only a single case report, you can follow the patient's clinical response following each of the interventions. And what changed the course of this patient's clinical condition was the intravenous NAC at 100 milligrams per kilogram, which for her probably came out around 7 grams per day. So she was crashing when she was treated only with drugs. They gave her the NAC, she recovered. They switched her to oral low-dose therapy, and she crashed again. They gave her the intravenous NAC at high dose again, 7 grams per day, and then that's what saved her. So again, even though it's an N of 1 or a single case report, the fact that her case went downhill, uphill, downhill, and uphill, with each uphill improvement coinciding with the administration of high-dose NAC, that's what shows you that NAC is what saved the day here. So interesting and successful case, very supportive data. And the authors also note, and I'll just mention it for the sake of completeness here, NAC is pregnancy category B, which means no obvious risk per animal studies and no strong data either for or against in humans. Pregnancy category B includes vitamins, acetaminophen, and several other medications that are used routinely and safely during pregnancy.